I think the value of a local commissioning champion became very clear in the first part of the work that we did during the trial. It was somebody who really championed our cause in health with their colleagues, and we've learnt from that now moving forward into the commissioning of the project nationally. We're finding it's very important to have either a champion in health or in a local service, or perhaps in the crime and disorder reduction partnership. So it doesn't really matter initially which area of professionalism that person is based in. The clinical lead will become really key when we've established that the project is going to run ahead in an area. And I think again it's multifold. So the clinical lead will work very closely with the advocate-educator for the area in terms of delivering the training, but even before that in terms of getting other clinical colleagues on board, so in the recruitment of the practices, and really acting as a kind of champion to spearhead the project in the area. Certainly in the trial, we found it was very helpful to have a peer saying, well, you know, I found this difficult, but I found a way of working with the project, of working my way through this difficult issue, and, you know, I'm doing the same job as you can, and it is hard, but we can support you to make it easier, and so that you feel more comfortable with the issue and that you're better supporting your patients. The role of the advocate-educator is really a broker working with lots of different people throughout the project. In terms of establishing the project in a local area, the role is really to liaise with the commissioning leads, whether they be in health or the local specialist service, and really build a positive relationship in both those areas. I think then moving on, once the project has been commissioned, this is when the role is really key. The advocate-educator has a dual role, as the name implies. So the educator part comes first. Being based in a specialist service, they bring all the knowledge and expertise of somebody working in the field of domestic violence into the health setting. And then they're working with their clinical colleague, the clinical lead, to deliver training to professionals within primary care. So they can bring not only the perspective of being a patient themselves, because that was my only experience of working in health before I started in this work and the IRIS project, but also they bring patient focus to the project and experience of working with victims and survivors. They act as a consultant within the practice once the training is ended, so they are available by phone, fax, email for any comments or questions or queries that any of the clinical staff have, whether that be a phone call to check whether a referral is appropriate, or perhaps following up after a patient has been referred, very much checking back in with the referring clinician to ensure that the care is being followed up and that the clinician is kept in contact with everything that's going on with his or her patient. And I think the second part, the advocacy part, is really key as well. So it's an interesting dual role. And the advocacy is working one-to-one with whoever the patients are who've been referred by the clinicians, and acting as a broker. So probably within the first instance, a listening ear, offering choices, offering support, and putting together a safety plan for the patient who's been referred. But more than that, once the patient's had a chance to really talk through what's been going on for her, where she's at, what she feels she needs, the advocate can bring in a whole raft of choices, whether that be around counselling and emotional support or practical support in terms of housing, refuge provision, housing benefit and other benefit, and support around children getting back into work or into training. We've had a range of responses really when we've contacted control practices, and some of the negative responses, if you like, have been to do with clinical things that are happening for them at the time. For example, swine flu a few months ago was quoted as a reason why a practice didn't want to get involved. They felt they had too much on their plate, they had competing priorities, and unfortunately we didn't meet their priority list. Sometimes we've struggled to get past gatekeepers when we've contacted practices, for example practice managers. Part of their role obviously is to sift out what they think is important and perhaps less important before it gets to the clinicians. And unfortunately sometimes we've struggled to get past the gatekeepers, although we've been advised that our message has been passed on and the response has come back thanks but no thanks at the moment. An interesting response I had from one practice was, well, all our clinicians are very experienced. They've been working in this area for a long time. Domestic violence is a problem within this patient population, so they're actually well used and well versed to working with patients and offering options. And I just felt that was a shame, really, because, you know, I tried to sort of talk them through, we're offering something new, something different, something innovative. We're coming to you, we're not asking for you to make an effort to come out and meet with us anywhere out of the ordinary. And actually your colleagues on the site that you operate from as well, out of this very health centre, have found it very positive experience, have referred a number of patients and seen really positive patient outcomes. So, you know, I'm really sorry that you don't feel able to take this up at the moment. But we keep trying. In Bristol, our advocate-educator, moving from the trial to service, started a few months ago, and she is still following up with those 4 practices in Bristol, the control practices that chose not to take up the training at the time we offered it to them.